If you dislocate your shoulder at age 18, you have up to a 90% chance of doing it again.
Which is an absolutely staggering statistic when you really think about it.
Right, I mean, up to 90%. But if you suffer the exact same injury with the exact same force at age 45, your chance of recurrence drops to around 10%.
Same joint, same trauma, but an entirely different biological destiny.
Exactly. Today, we are figuring out exactly why that is. Welcome to this deep dive. This session is custom tailored for you, the listener.
Whether you're an emergency medicine physician running a busy trauma unit or an orthopedic trainee preparing for those final fellowship exams.
Our mission today is to build a really robust, structured framework for managing shoulder instability. We're going straight from that Friday night emergency department presentation all the way through to the highly complex, three-dimensional bone loss reconstructions that happen in the specialist theater.
We are unpacking the biomechanics, the historical debates, and crucially, the exact clinical thresholds that dictate whether a patient gets a simple sling or a massive bone transfer.
It's the perfect place to start, actually, because shoulder instability is just consistently underestimated across the board.
Oh, absolutely. There's this pervasive, frankly outdated notion in acute care that a dislocation is just a temporary mechanical glitch. You know, the joint pops out, a clinician pops it back in, you get that satisfying clunk, and the problem is supposedly solved.
Right, wash your hands and send them home.
Exactly. But viewing it through that rudimentary lens does a massive disservice to our patients. It is not a singular, isolated event.
No, not at all.
I mean, every single time that humeral head leaves the socket, it triggers a cascade of microstructural damage to the capsule, the labrum, and the bone itself. We really have to fundamentally stop treating the shoulder like a simple hinge on a door.
Right, and recognize it as this highly sophisticated dynamic linkage that demands completely bespoke interventions. Let's actually visualize that linkage for a moment.
It's easier.
Because in medical school, we're often given that tired analogy of the shoulder being like a golf ball on a golf tee.
Which is far too stable of an image, to be honest.
Exactly. I actually think that drastically understates the precariousness of the anatomy. I mean, the hip joint is a true ball and socket, right? The bone physically wraps around the femoral head.
It's highly constrained by the skeletal architecture.
Right. But the shoulder is more like trying to balance a heavy grapefruit on a slightly curved saucer.
That's a brilliant way to picture it.
You are entirely dependent on this intricate network of bungee cords, your ligaments, and a small rubber suction lip around the edge of the saucer, which is the labrum.
Which is an evolutionary marvel, really. I mean, it allows us to throw a javelin or climb a vertical wall.
But it completely sacrifices bony stability to achieve that extreme mobility. So when that grapefruit is violently knocked off the saucer for the very first time, the foundation of how we manage it is just absolutely critical.
It is the defining moment in the pathology. And to understand the trajectory, we have to look closely at that index event, you know, that first-time dislocation.
Which used to be quite controversial, didn't it?
Oh, fiercely debated. For decades, the global orthopedic community argued over the natural history of this injury. The core question was, if we just leave it alone, what actually happens over time?
And the data that finally cut through all that noise came from the landmark longitudinal studies by Hovelius and his colleagues.
Spot on. They did something quite extraordinary. They tracked cohorts of first-time dislocators over immense timeframes. Initially 10 years, and then 25 years.
Which is almost unheard of in modern follow-up studies.
Exactly. And from that data, they isolated the single most vital clinical pearl. The age of the patient at the exact moment of their first dislocation is the absolute strongest predictor of whether they will dislocate again.
Let me stop you right there because we hear age as a factor in almost every medical condition under the sun. But how stark are the actual numbers here?
They are completely night and day.
Are we talking about a slight statistical bump for a teenager? Or is it a complete paradigm-shifting reality depending on the birth year of the patient sitting in front of you?
It is a totally different reality. The Hovelius data showed us that if a patient is under the age of 20 when they suffer their first traumatic anterior dislocation, their rate of recurrent instability is exceptionally high.
We're talking up to 90%, right?
Exactly. If managed non-operatively, between 70 and 90% of those teenagers will experience recurrent dislocations or symptomatic subluxations.
And the older cohort.
In stark contrast, if a patient is over the age of 40 at the time of their first dislocation, the recurrence rate drops precipitously down to around 10 to 15%.
Hang on, why is that disparity so extreme? I mean, is it purely behavioral?
Hmm.
We naturally expect the 18-year-old is going straight back out to the rugby pitch on a Saturday, whereas the 45-year-old might take it a bit easier.
Behavior plays a role, sure, but the biological differences are actually profound.
So it's the tissue itself.
Absolutely. In a teenager or a young adult in their early 20s, the capsulolabral tissues, those bungee cords and that rubber suction lip you mentioned, they are highly elastic, thick, and incredibly resilient.
So it takes a lot to break them.
Exactly. For a high-velocity trauma, to actually rip the anterior labrum right off the bone, which creates what we call a Bankart lesion, it requires immense kinetic energy. That energy stretches the inferior glenohumeral ligament complex to its absolute limit.
Right. The ligaments are stretched beyond their yield point,
And here is the kicker. Because younger tissue is highly compliant, it heals with inherent laxity. It just doesn't scar down tightly.
which leaves the joint permanently loose.
Precisely. Now, conversely, in a 45-year-old, the collagen cross-linking is totally different. The capsular tissues are naturally stiffer.
So they don't stretch in the same way during the trauma.
Exactly. When they dislocate, they frequently sustain a different pattern of injury altogether. Instead of strictly tearing the labrum, they might actually tear their rotator cuff.
Oh, wow. Which is a completely different management pathway.
Exactly. Furthermore, their joint capsule has a natural tendency to stiffen significantly during the inflammatory healing phase. That post-injury stiffness acts as a biological restraint, inherently limiting recurrent instability.
So their own stiffening response protects them.
Spot on. Couple that stiffening response with the fact that they aren't taking high-impact tackles every single weekend, and their recurrence rate just plummets.
Which brings up a massive historical controversy in sports medicine. I mean, historically, the absolute dogma for a first-time dislocator was conservative management.
Oh, yes, the standard protocol.
Right. You immobilize the arm in a poly sling, you hand them a rather generic physiotherapy leaflet, and you just hope they're in the lucky minority who don't redislocate. Surgery was strictly a salvage operation for chronic dislocators.
It was almost a badge of honor to avoid the theater.
But looking at this Hovilius data, if we know a 19-year-old rugby player has a 90% chance of failing conservative treatment, aren't we committing a form of clinical negligence by just putting them in a sling and waiting for it to pop out again?
You are touching on the exact debate that has entirely reshaped modern sports orthopedics over the last decade.
It's a massive shift in mindset.
It is. If we have a high-demand patient with a statistical likelihood of recurrence nearing 90%, putting them in a sling is not just delaying the inevitable. It is actively permitting irreversible damage.
Right, because the damage accumulates.
Exactly. You really have to think about what happens inside the joint with every subsequent dislocation. It acts like a geological erosion event.
Oh, that's a brilliant way to phrase it.
Each time that humeral head lever arms forcefully out of the socket, the back of the ball grinds against the front of the saucer. It physically chips away the anterior glenoid bone and gouges a massive dent into the posterior humeral head.
So by waiting, we're making the eventual surgery so much harder.
Precisely. By adopting a passive wait-and-see approach in a high-risk youth, we are taking a relatively simple soft tissue injury, a torn labrum that is easily repairable, and we are allowing it to evolve into a catastrophic bone loss problem.
A problem that will eventually require a major bony reconstruction.
Exactly.
Let's make this highly tangible for our listener. Imagine you are running a specialist shoulder clinic. 2 patients present on the exact same afternoon, both 2 weeks post-injury.
Okay, set the scene.
Patient A is an 18-year-old academy rugby player who dislocated his shoulder during a high-speed tackle. Patient B is a 45-year-old recreational tennis player who tripped over her dog in the garden and dislocated her shoulder, breaking her fall.
A very classic clinic list.
Right. Both had perfect post-reduction radiographs in the emergency department. So how does your clinical algorithm diverge for these 2 specific individuals?
The divergence is absolute right from the moment I open the consultation door.
Let's start with the tennis player.
For the 45-year-old tennis player, the algorithm strongly favors non-operative management. Her biological risk of recurrence is incredibly low.
So no surgery chat at all.
Rarely. I would ensure she only uses a sling for comfort for a few days, and then I would aggressively commence physiotherapy to restore her range of motion and strengthen her dynamic stabilizers.
Meaning her rotator cuff and parascapular muscles.
Exactly. My primary clinical anxiety for her is actually ruling out a concomitant rotator cuff tear or axillary nerve neuropraxia.
Which is essentially a Stretching or bruising of the nerve that temporarily paralyzes the deltoid muscle. Right.
Spot on. If she can lift her arm actively and her nerves are completely intact, surgery is completely off the table. Unless, of course, she proves to be the rare exception who develops chronic instability later.
Fair enough. And when the 18-year-old rugby player walks in,
The conversation immediately shifts to early surgical intervention.
you bring it up on day one.
Absolutely. I sit down with him and his parents and frankly explain that without an operation, his shoulder will almost certainly fail the exact moment he returns to contact sport.
Because the bungee cords are already too loose.
Right. I explicitly outline the concept of cumulative bone loss to them. In modern practice, the consensus strongly dictates offering this specific patient a primary arthroscopic stabilization.
So we want to secure that soft tissue damage immediately.
Precisely. Proactively halting the cascade of instability before he literally grinds his glenoid bone away on the pitch.
So causality drives us from conservative management into the operating theater. The soft tissue has failed, and we absolutely need to fix it before the bone gets destroyed.
That is the modern paradigm, yes.
But what exactly are we fixing? I mean, let's take the listener inside the joint.
Yeah.
When you put the camera into that 18-year-old's shoulder, what does the pathology actually look like?
To truly appreciate the pathology, we have to travel back a bit. Back to 1938 to the pioneering anatomical work of Arthur Sidney Blundell Bankart.
A legendary name in orthopedics.
Truly. He was an English orthopedic surgeon who was the very first to accurately isolate and describe the essential lesion of recurrent anterior shoulder instability.
What did he actually find?
Bankart observed that when the humeral head dislocates anteriorly, it acts exactly like a battering ram. It violently avulses the anteroinferior labrum, that rubber suction lip we talked about, and the attached joint capsule right off the anterior bony margin of the glenoid.
And this detachment is universally known today as a Bankart lesion.
Exactly. When that complex is stripped away, the restraining bungee cords lose their firm anchor point, and the front lip of the saucer is just gone.
Leaving nothing to stop the grapefruit from rolling off.
Precisely. The grapefruit can simply slide forward with minimal provocation.
Now, Bankart originally described fixing this through a highly invasive open surgical approach, didn't he?
He did. It was quite a major undertaking.
Right, making a large incision, physically cutting through the subscapularis muscle at the front of the shoulder, and actively drilling holes to sew the tissues back to the bone.
It was robust, but the morbidity was significant.
But we live in the modern era now. We transitioned heavily over the last few decades to arthroscopic Bankart repairs.
The keyhole revolution.
Exactly. Using tiny incisions, a high-definition fiber optic camera, and incredibly sophisticated suture anchors that tap directly into the bone. It preserves the muscles, it looks incredibly elegant on the surgical monitors, and initially it really felt like a total revolution.
It was celebrated as the ultimate solution.
But, as we see so often in medicine, the pendulum swung way too far. Surgeons started arthroscopically repairing absolutely everyone.
And that is where we got into trouble.
Right. Because then the data caught up, showing that a very specific subset of these patients were failing miserably. Their shoulders were redislocating despite having a technically perfect soft tissue repair on the screen. Why was the arthroscopic revolution failing them?
It failed because we fell victim to the allure of the scope.
The technology blinded us a bit.
Exactly. The minimally invasive technique was so technically satisfying that we momentarily forgot to respect the immense biomechanical forces acting across the joint.
It's just soft tissue at the end of the day.
Right. An arthroscopic Bankart repair is phenomenal for precisely mobilizing and re-anchoring soft tissue. However, if you place a high-demand athlete under extreme physiological load like a rugby player reaching out to tackle a fast-moving opponent's soft tissue alone, simply cannot hold that force if the underlying skeletal architecture is compromised.
The anchors will just rip out.
Spot on. This harsh realization prompted a period of intense critical evaluation regarding our failure rates. And it culminated in the development of one of the most critical preoperative scoring systems in modern shoulder surgery.
The Instability Severity Index score, or, as we all know it, the ISIS score, developed by Balg and Boileau.
Yes, a truly fundamental tool.
The ISIS score is absolutely essential for anyone managing these patients today. And just to be completely clear for the listener, this isn't a diagnostic tool to tell you if the shoulder's unstable.
No, we already know it's unstable.
Right. It is a predictive tool strictly utilized to tell you if an arthroscopic Bankart procedure is going to fail.
Which is a brilliant distinction.
So how did Balg and Boileau actually build this framework?
They conducted a meticulous retrospective analysis of a large cohort of patients who had undergone arthroscopic Bankart repairs. They were explicitly hunting for preoperative variables that statistically correlated with postoperative surgical failure.
And they narrowed it down to 6 factors. Wait,
Exactly. 6 critical parameters, each assigned specific point values based on their weight.
let's walk through them.
First, if the patient is under 20 years old at the time of surgery, they score 2 points.
Because of that tissue elasticity we discussed.
Right. Second, participation in competitive sports scores 2 points. Third, participation in contact or forced overhead sports scores 1 point.
So sport alone can give you up to 3 points.
Exactly. Fourth, the presence of anterior glenoid bone loss visible on a standard AP radiograph scores 2 points. Fifth, the presence of a Hill-Sachs lesion on the humeral head visible on an AP radiograph in external rotation scores 2 points.
So bone damage is heavily weighted.
Immensely. And finally, if an MRI shows the absence of a robust inferior glenohumeral ligament, that scores 2 points. The total score is out of 10.
Okay, so let's apply that practically. Our 18-year-old competitive rugby player, with even a subtle hint of bone damage on his x-ray, is immediately racking up a score of 7 before you even physically touch him.
He hits 7 almost instantly, yes.
So what is the hard clinical threshold here? Where do we draw the line and just say arthroscopy is off the table?
The Belgian-Boileau established that if a patient's ISIS score is over 3, their risk of recurrence after an isolated arthroscopic soft tissue repair begins to climb uncomfortably high.
Over 3 is already a warning light.
Exactly. But if the score is over 6, the recurrence rate in their original cohort was staggering, reaching up to 70%.
70% failure rate. That's unacceptable.
Completely. Therefore, an ISIS score over 6 represents an absolute hard stop in clinical decision-making.
It fundamentally dictates that an arthroscopic soft tissue repair will fail biomechanically.
Precisely. The patient's age, sport, and anatomical deficits demand that you abandon the scope and perform an open bone block procedure like a Latarjet to provide rigid mechanical stability.
That requires a massive ego check for a surgeon, doesn't it?
Oh, without a doubt.
I mean, the internal monologue has to shift from the technical vanity of, look how well I can sew this labrum through a tiny keyhole, to the mature, evidence-based reasoning of, the statistics prove my perfect stitching will rip out in 6 months.
You've hit the nail on the head. It strips away the one-size-fits-all mentality. When I consult with a young athlete who scores a 7 on the ISIS scale, the entire tone of the preoperative discussion changes.
It's no longer a quick fix.
Not at all. I have to look them straight in the eye and explain that a quick, day-case arthroscopy is biologically insufficient for their demands. We have to discuss making a larger incision, transferring a block of bone, and permanently altering their shoulder anatomy to guarantee stability.
It is a much heavier, more sobering conversation.
It is, but it categorically prevents the devastating physiological and psychological toll of a failed surgery and a horrific revision operation down the line.
And the primary driver of that high ISIS score, the real villain behind why soft tissue repairs fail so spectacularly, brings us to the absolute core of shoulder instability.
The bone itself.
Exactly. It is not the soft tissue tearing. It is the underlying bone crumbling away. I often imagine trying to pitch a high-tech, expensive tent in dry, crumbling. You can have the absolute strongest titanium pegs and the thickest guy ropes in the world. But if the ground you were driving those pegs into is just giving way, the first strong gust of wind is going to rip the whole structure out of the earth.
It's inevitable.
So let's explore this crumbling foundation. What exactly is glenoid bone loss? And why does it guarantee the failure of a Bankart repair?
Well, your tent analogy is brilliantly accurate. The anterior margin of the glenoid is the soil. Every single time the shoulder dislocates, the hard, dense bone of the posterior humeral head smashes against the relatively fragile anterior inferior rim of the glenoid.
It's basically a hammer hitting a ledge.
Exactly. Over repeated dislocations, or sometimes even during one incredibly violent index trauma, a segment of that rim fractures off or simply erodes away like a cliff face under crashing waves.
And this is what we refer to as glenoid bone loss.
Precisely. Now, if you attempt to anchor a repaired labrum onto a glenoid that has lost a significant percentage of its surface area, you are effectively attaching your bungee cords to a significantly narrower, flatter saucer.
Which totally compromises the mechanics.
Right. The soft tissue repair will look pristine on the surgical monitor. I mean, it will look beautiful. But the moment the athlete abducts their arm and aggressively externally rotates, like cocking their arm to throw a baseball, the humeral head will simply lever right over that deficient rim.
Ripping everything out.
It rips the suture anchors right out of the remaining bone, and the joint dislocates again.
Which means quantifying exactly how much soil is missing before we operate is the absolute most critical step in preoperative planning.
Unquestionably.
And here is a major clinical trap that catches out junior doctors and emergency physicians constantly. And that is relying on an MRI to measure bone loss.
Oh, it's a huge pitfall.
Because we use MRI for almost everything in orthopedics, right? Mapping cartilage, identifying subtle rotator cuff tears, looking at labral pathology. But for bone loss, MRI consistently and dangerously underestimates the defect. Why does the MRI lie to us, and what should we be demanding instead?
Well, MRI is a magnificent modality for resolving soft tissue contrast. There's no debating that. But its fundamental physics struggle to accurately delineate the exact, crisp margins of cortical bone.
Especially in a traumatized joint.
Exactly. This is particularly problematic at the anterior glenoid rim because following a dislocation, the area is flooded with a highly complex matrix of fibrous scar tissue, organized hematoma, and compacted cartilage.
It's a mess in there.
It is. And on a standard MRI sequence, this dense scar tissue generates a signal void that masquerades brilliantly as intact bone.
So the radiologist looks at the scan.
The radiologist and the surgeon look at the scan and mistakenly believe the structural foundation is intact, severely underestimating the true bony deficit.
Which leads to the wrong surgical plan.
Exactly. The absolute, undeniable gold standard for quantifying glenoid bone loss is a computed tomography scan, a CT scan.
Specifically formatted, right?
Yes, specifically formatted with 3D reconstructions and on-face views of the glenoid, where the software digitally subtracts the humeral head entirely so you can look straight down at the bare socket.
Okay, so picture this. You have this pristine 3D on-face view of the glenoid socket right on your screen. You're looking directly at the bare bone. How do you actually calculate the percentage of bone that has crumbled away?
It's a very specific geometric process.
Because we constantly hear the term best fit circle in multidisciplinary team meetings. Walk the listener through how you actually draw that circle.
Sure, visualize looking straight down into the bowl of the glenoid, similar to looking at the face of a clock. The inferior 2/3 of a healthy native glenoid is almost perfectly circular in shape.
It really is. It's remarkably consistent.
It is. The best fit circle method leverages this consistent anatomy. We use digital templating software to manually draw a perfect circle that precisely matches the curvature of the intact inferior and posterior margins of the patient's own glenoid on that CT scan.
So you trace the good bone to find the original shape.
Exactly. Now, because the anterior bone has eroded away from the dislocations, the front portion of the circle we just drew will project out into empty space.
Out where the bone should be if it hadn't broken off.
Spot on. By calculating the surface area of that missing segment, the void inside the circle, and comparing it to the total surface area of the drawn circle, we arrive at a highly accurate objective percentage of glenoid bone loss.
It's pure mathematics.
It is. Alternatively, some surgeons measure the linear diameter of the circle and compare it to the remaining width of the bone. But regardless of the mathematical approach, it strips away the guesswork entirely and gives us a hard, actionable number.
And getting that hard number throws us right into the middle of one of the most fiercely debated topics at orthopedic conferences worldwide.
Ah, the threshold debate.
Exactly, the threshold percentage. What is the exact percentage of bone loss where soft tissue repair is doomed and bone augmentation becomes absolutely mandatory?
It's been a moving target for years.
It really has. For years, the textbooks rigidly stated that 20 or 25% bone loss was the absolute cutoff. But over the last decade, that number has been steadily creeping down in the literature.
Significantly down.
We now see major guidelines citing thresholds anywhere from 13.5% to 20%. Now, if the guidelines give us a range spanning 13.5 to 20%, that is a massive, ambiguous gray zone for a surgeon making a critical operative decision.
It is a very uncomfortable zone to sit in.
So how do you personally navigate that subcritical gray area in your own practice?
Well, the evolution of this threshold is a fascinating reflection of how our biomechanical understanding has genuinely matured.
We used to just look at the gross defect.
Right. But the pioneering biomechanical studies, particularly the incredible work by E.G. Hitoy and his team, demonstrated how dramatically stability drops off even with seemingly small bony defects.
Which changed everything.
It did. Both the ISICO's consensus statements and the British Orthopedic Association guidelines now formally recognize the concept of subcritical bone loss. We no longer treat 20% as a magic number.
But 20% is still the absolute ceiling, right?
Oh, let's be entirely clear on that. 20% is universally accepted as critical bone loss.
No.
If you are missing a fifth of your glenoid, a Bankart repair will fail instantly. You must perform a bone augmentation.
No debate there.
None. However, that 13.5% to 20% range, that subcritical zone, is where the art of medicine truly meets biomechanics. In this gray zone, an isolated soft tissue repair might theoretically survive in a low-demand patient, but it will almost certainly fail in a high-demand contact athlete.
So the equation isn't just a simple mathematical threshold on a CT scan anymore. You have to actively marry the precise percentage of bone loss to the patient's physiological demands and kinetic environment.
Exactly. It requires holistic clinical profiling. If I have a 22-year-old competitive rock climber or martial artist with exactly 15% bone loss, that defect is mathematically subcritical, but it is highly critical functionally.
Because of the force they put through the joint.
Right. Their mechanical demands wildly exceed what that slightly compromised saucer can tolerate. I will navigate that gray zone by firmly advising a bone block procedure, like a Latarjet.
To give them the mechanical advantage back.
Precisely. Conversely, if I see that exact same 15% bone loss in a 40-year-old who strictly swims breaststroke for fitness, an arthroscopic soft tissue repair coupled with a robust capsular application might be entirely sufficient.
Which brings us right back to the imaging point.
This is exactly why getting the imaging right is paramount. If you rely on an MRI and it underestimates a 16% defect as an 8% defect,
You completely miss the
You do. You will erroneously perform a simple arthroscopic repair on a high-level athlete. And that specific cascade of diagnostic errors leads directly to catastrophic postoperative redislocation.
We have spent the last 30 minutes meticulously analyzing the socket, the glenoid, and its crumbling rim. But causality dictates we have to look at the other side of the impact.
Ball.
We need to look at the ball. Because when that shoulder violently dislocates anteriorly, the posterior aspect of the humeral head gets physically impaled on the sharp anterior rim of the glenoid, causing a really deep impaction fracture.
The classic Hill-Sachs lesion.
Exactly. Historically, we used to just note its presence on an X-ray, maybe comment on its size, and essentially move on.
It was almost treated as an incidental finding.
Right. But our understanding has been completely revolutionized by the introduction of the glenoid tract concept by Giovanni Di Giacomo and his colleagues back in 2014. What exactly is the glenoid tract, and how does it separate a harmless Hill-Sachs lesion from a genuinely dangerous one?
The glenoid tract concept was nothing short of a paradigm-shifting revelation in our field. Prior to Di Giacomo's 2014 paper, we analyzed the glenoid and the humerus as completely isolated, static entities.
We treated them like two separate problems.
Exactly. We measured glenoid bone loss, we measured the Hill-Sachs lesion, and we essentially tried to fix them separately. Di Giacomo forced the orthopedic world to view the shoulder as a dynamic, moving mechanism.
Which it is.
Right. The glenoid tract is essentially the specific footprint of contact that the glenoid socket makes as it slides across the posterior articular surface of the humeral head during the arm's most vulnerable arc of motion.
Which is extreme abduction and external rotation. The throwing position.
Exactly. Imagine a distinct footprint sliding across the back of the ball. Extensive biomechanical mapping determined that the width of this functional tract is approximately 83% of the width of the intact glenoid.
Okay, so we map out this tract based on the patient's individual anatomy. And we specifically subtract any anterior glenoid bone loss because losing that anterior bone would naturally narrow the overall width of that footprint, right?
Spot on. You have to account for the missing soil.
So how does the Hill-Sachs lesion actually interact with this dynamic tract we've mapped out?
This is where we assess what we call engagement. We measure the total width of the Hill-Sachs lesion and see exactly how far medial it extends on the humeral head. We then digitally superimpose that measurement onto our calculated glenoid tract.
To see if they cross over.
Precisely. If the entire Hill-Sachs lesion stays safely within the boundaries of the glenoid tract during that dynamic throwing motion, it is classified as an on-track lesion.
And mechanically, an on-track lesion is relatively benign, isn't it?
It is. The glenoid rim never physically falls into the defect, so it doesn't pry the joint out of place. A soft tissue repair is usually perfectly adequate there. However, if the Hill-Sachs lesion is exceptionally wide, Or more crucially, if it extends medial to the inner boundary of the glenoid tract, it becomes an off-track lesion.
Let me bring in an analogy here to make this physical interaction crystal clear for the listener, because I often compare an off-track Hill-Sachs lesion to a massive pothole on a really narrow country road.
I like where this is going.
The tire of your car represents the glenoid rim, and the road surface is the humeral head. Now, if you have an on-track lesion, the pothole is either quite small, or it is located safely off to the hard shoulder of the road.
Out of the way.
Right. Your tire can drive straight past it without ever catching the edge. But if the road is significantly narrowed because of glenoid bone loss...
The track is smaller.
Exactly. And the pothole is wide and positioned right in the middle of your driving lane. That is an off-track lesion. As the tire rolls over it, the wheel drops violently into the pothole, catches the sharp edge, the steering wheel jerks, and the entire car is levered violently off the road.
That is a phenomenal visual.
That is the exact biomechanical mechanism in the shoulder, isn't it? The anterior glenoid rim drops into that deep Hill-Sachs defect, mechanically engages, and leverages the joint completely out of the socket.
That analogy captures the kinetic reality perfectly. It describes exactly what the patient physically feels when an off-track lesion engages.
That awful catching sensation.
Yes. When they bring their arm up into the late cocking phase of a throw, the intact anterior glenoid rim literally drops into the bony pothole on the back of the humeral head.
Which locks the joint.
The joint momentarily locks. That is the engagement we talk about. And then, as the momentum of the arm continues backward, the humerus leverages itself violently right out the front of the joint.
It's terrifying for the athlete.
It is. This bipolar bone loss, meaning damage to both the socket and the ball, really mandates that we treat the joint as a fully integrated mechanical linkage. We categorically cannot simply fix the saucer and ignore a massive pothole on the grapefruit.
Having identified this off-track lesion as a mechanical time bomb,
Yeah.
I mean, it's a guaranteed mechanism for failure if we ignore it. What advanced reconstructive tools do we actually use to prevent that tire from catching the pothole?
This pulls us into the realm of complex open surgery.
Right. Specifically, the Latarjet procedure and the remplissage. Let's start with the ultimate heavy-duty solution for severe bipolar bone loss, the Latarjet. We touched on it a bit earlier, but let's explore its fascinating history and biomechanics. It dates all the way back to the 1950s in France, doesn't it?
Indeed, it was first described by the visionary French surgeon Michel Latarjet back in 1954.
But it wasn't always as popular as it is today.
No, for several decades, particularly during the peak of the arthroscopic boom in the 90s and 2000s, it was largely relegated to being a salvage procedure. An operation of absolute last resort when all your fancy keyhole surgeries had failed.
A rescue mission.
Exactly. But as our understanding of bone loss and the glenoid tract matured, and we finally realized the complete futility of soft tissue repairs in high-risk scenarios, the Latarjet has experienced a massive, well-deserved resurgence.
This is incredibly common now.
It is now widely considered a primary surgical option for contact athletes with structural deficits, and the procedure itself is anatomically ingenious.
Let's break down the anatomy of the transfer.
It involves osteotomizing or cutting the coracoid process, which is a finger-like bony projection extending from the front of the scapula. We take that piece of bone, along with a conjoint tendon that attaches to it, and we transfer it down to the deficient anterior-inferior rim of the glenoid, securing it typically with 2 screws.
But the reason the Latarjet is so phenomenally successful isn't just because we are bolting a spare piece of bone to the front of the joint to physically make it wider.
Not at all. That's only part of it.
It is, because it generates what is consistently termed the triple blocking effect. I really want to break this down step by step because understanding this biomechanical synergy is absolutely crucial for any trainee. How do the bone and the transposed tendons act together to form this dynamic restraint?
The biomechanical brilliance of the Latarjet is exactly that triple block. Component 1 is the static bone block effect.
So just the physical presence of the bone.
Exactly. By rigidly fixing the coracoid to the front of the glenoid, we physically restore or even slightly over-augment the articular surface area. We are functionally lengthening the bony arc of the saucer, preventing the humeral head from sliding over the edge.
Right, that's the static barrier. What's component 2?
Component 2 is the sling effect, and this is dynamically the most powerful aspect of the entire procedure.
How does that work?
Well, the transferred coracoid brings its native soft tissue attachments with it. specifically the conjoint tendon, which is comprised of the short head of the biceps and the coracobrachialis. Now, when the patient abducts and externally rotates their arm into that highly vulnerable throwing position,
The tendon tightens up.
exactly. It acts exactly like a taut hammock or a seat belt stretched across the inferior capsule and the lower half of the subscapularis muscle. As the arm moves, the seat belt tightens, physically barring the lower humeral head from translating anteriorly.
It's an active muscular restraint.
It's brilliant. Finally, component 3 is the capsular repair. We physically suture the native capsule to the stump of the coracoacromial ligament, which cleverly remains attached to our transferred bone block, effectively restoring the tension of the overall joint capsule.
So it's bone, muscle sling, and capsular tension.
Yes. This intricate synergy of static bone augmentation and dynamic muscular tethering provides unparalleled, robust stability.
It sounds like an anatomical masterpiece. But let me push back slightly on the surgical application here,
Go ahead.
because it is notoriously difficult to perform well. There is an ongoing, highly contested debate in the major literature right now. Journals like Arthroscopy, the American Journal of Sports Medicine, regarding open versus arthroscopic Latarjet procedures.
A very hot topic.
If the arthroscopic approach failed us so spectacularly with Bankart repairs in high-risk patients, why on earth are surgeons attempting to perform this incredibly complex bone transfer through a keyhole? What is the reality of that learning curve?
Well, the drive towards the arthroscopic Latarjet predominantly stems from the desire to minimize surgical morbidity, reducing tissue dissection, lowering immediate postoperative pain, and potentially speeding up early rehabilitation.
The same promises as the arthroscopic Bankart.
Exactly. However, you're absolutely right to highlight the severe steepness of the learning curve. It is arguably one of the most punishing and technically demanding procedures in all of orthopedic sports medicine right now.
You're working in a really dangerous area.
Extremely dangerous. You are passing drills, screws, and literal blocks of bone through narrow portals while navigating millimeters away from major neurovascular structures, specifically the musculocutaneous and axillary nerves.
One slip and the patient has a permanent deficit.
Precisely. And the outcome data in those high-impact journals is quite revealing. It shows that while master arthroscopists, the absolute top 1%, can achieve equivalent results, the complication rates during a normal surgeon's learning phase are genuinely concerning.
What kind of complications are we seeing?
Things like graft non-union, screws missing the target entirely, graft osteolysis, or, as you mentioned, devastating nerve neuropraxia. These rates are unacceptably higher compared to the classic open approach.
So open is still king for most.
For the vast majority of orthopedic surgeons worldwide, the open Latarjet remains the absolute gold standard because it delivers excellent, highly reproducible results without exposing the patient to the extreme risks of that arthroscopic learning curve.
That makes perfect sense. Reproducible safety must always supersede surgical aesthetics. But what if we encounter a scenario where the bone loss hasn't quite reached the critical threshold to justify a major coracoid transfer?
Ah, the intermediate pathology.
Right. Let's say we have an off-track Hill-Sachs lesion, a deep pothole, but the glenoid bone loss is minimal, maybe only 5%. We absolutely have to address that pothole to prevent the joint from engaging and levering out. But we don't really want to subject the patient to the morbidity of Latarjet.
It would be overkill.
Exactly. This is the exact indication for the remplissage procedure. And remplissage literally translates from French to fill. How does this technique elegantly solve the off-track problem?
When an off-track Hill-Sachs lesion is the primary threat to stability, but the anterior glenoid bone loss is subcritical, we perform a combined arthroscopic procedure, a standard Bankart repair at the front, coupled with a remplissage at the back. We literally fill in the pothole.
So you do both from the inside.
Yes, working purely arthroscopically. We place suture anchors directly into the depth of the bony defect on the posterior humeral head. We then pass those heavy sutures through the overlying infraspinatus tendon and the posterior joint capsule, and we firmly tie them down.
Yanking the tendon into the hole.
Exactly. This physical tethering pulls the tendon and capsule deep into the bony defect. Crucially, it makes the defect extra-articular. It physically sits outside the joint capsule now.
So the front rim can't catch it anymore.
Right. Because the pothole is completely filled with soft tissue and entirely excluded from the joint space, the anterior glenoid rim simply cannot drop into it during rotation. The remplissage physically converts a dangerous off-track shoulder back into a safe on-track shoulder.
It is a brilliant spatial solution. Well, let me challenge the physiological consequence of that technique.
It's not a free pass, that's true.
By deliberately tethering the posterior joint capsule and the infraspinatus tendon deep into the humeral head, we are intentionally tying down the posterior structures of the shoulder. Are we not just sacrificing functional range of motion in exchange for stability?
We absolutely are.
So at what point is a remplissage functionally unacceptable? I'm thinking specifically of a high-level overhead athlete, like a baseball pitcher or a javelin thrower, who absolutely relies on maximum terminal external rotation to generate their throwing velocity.
That is the pivotal biomechanical trade-off of the remplissage, and it requires highly nuanced patient selection. Tethering those posterior structures inherently restricts external rotation, typically causing a permanent loss of between 5 and 10 degrees.
Which doesn't sound like much.
For the vast majority of the population, a rugby player taking a tackle, a skier, a recreational weightlifter, that slight loss of terminal rotation is functionally imperceptible. They genuinely won't notice it, and it is a very small price to pay for a rock-solid, stable shoulder.
But for the pitcher,
Your point about elite overhead throwing athletes is highly critical. For a professional baseball pitcher, a loss of even 5 degrees of external rotation alters their throwing kinematics so profoundly that it can completely decimate their velocity and effectively end their career on the spot.
so what do you do for them?
In those highly specific, hyper-elite cases, a remplissage is often strictly contraindicated. We might actually have to explore highly complex alternative biological grafts, like using a piece of distal tibial allograft to structurally fill the bone defect without actually tethering the rotator cuff.
A true bespoke reconstruction.
Exactly. It demands a highly individualized discussion regarding their career priorities versus anatomical stability.
That perfectly underscores just how bespoke shoulder reconstruction has become. You are literally engineering the joint for the specific kinetic demands of the sport.
Now, I want to pull the lens back significantly here.
Okay, let's zoom out. We've spent the last 45 minutes deeply dissecting traumatic, high-energy instability, and severe structural bone loss. But the reality of clinical practice is that not every unstable shoulder is the result of a massive rugby tackle or a catastrophic bone defect.
No, absolutely not.
Sometimes patients present with shoulders that just slip out of joint with trivial movements, like reaching for a seatbelt, or they present with vague, deep pain rather than an obvious dramatic dislocation. Let's shift our focus to what we call the zebras, the non-traumatic, the posterior, and the attritional forms of instability that frequently trap unwary clinicians.
These are the cases that keep you on your toes in clinic.
Exactly. Let's start with multidirectional instability, universally abbreviated as MDI. How does the pathology of MDI differ fundamentally from the violent traumatic cases we have been discussing?
Well, multidirectional instability represents an entirely different pathological and physiological spectrum. These patients do not suffer a discrete, high-energy traumatic avulsion of their labrum.
There's no Bankart lesion.
Rarely. Instead, their instability is primarily driven by global capsular laxity. They are often inherently hypermobile individuals, frequently scoring highly on the Baton scale for systemic joint laxity.
They're just naturally very stretchy.
Exactly. Their shoulder capsule is what we call patulous, meaning it is abnormally voluminous and redundant, like wearing a suit jacket that is 3 sizes too big.
It just hangs loosely.
Right. Because the capsule totally lacks tension, the humeral head can easily subluxate anteriorly, posteriorly, and crucially, inferiorly.
The classic party trick shoulder.
Yes. We clinically demonstrate this inferior laxity with a positive sulcus sign. When you pull downward on their relaxed arm in the clinic, a highly visible dimple forms under the acromion as the humeral head just drops straight down. In MDI, the labrum is usually perfectly intact. It is the oversized capsular envelope that is completely failing to provide a static restraint.
And because there is no discrete structural tear to physically sew back together, the entire treatment algorithm is basically flipped on its head. Surgery is no longer the proactive first step. It is the absolute last resort. Correct.
Entirely correct. The absolute cornerstone of managing multidirectional instability is intensive, prolonged, and highly specific rehabilitation.
Not just a generic leaflet this time.
Oh, definitely not. These patients almost universally suffer from profound scapular dyskinesia. Their parascapular muscles, the muscles intricately controlling the shoulder blade fire, completely out of sequence.
So they don't stabilize the socket dynamically?
Exactly. They failed to dynamically center the humeral head onto the glenoid saucer during arm movement. The physiotherapy program is not just about strengthening, it is about highly complex neuromuscular reeducation.
Retraining the brain, really.
Exactly. The physiotherapist acts essentially as a pacemaker for the shoulder girdle, painstakingly retraining the brain to actively compress the joint using the rotator cuff muscles to physically compensate for the loose capsule.
But what if they do all that and still fail?
Surgery is reserved strictly for the minority of patients who undergo a minimum of 6 to 12 months of dedicated, compliant rehabilitation and still experience debilitating symptomatic subluxations that prevent normal activities of daily living.
And what surgery do you actually offer them?
When we're forced to operate, we perform an arthroscopic capsular shift. We don't use bone blocks. We take that voluminous, oversized capsule and we meticulously pulplicate it, folding it over and suturing it to essentially tailor the suit to fit much more tightly around the joint, reducing the global volume.
Another crucial zebra in the instability world is posterior instability. We noted in the introduction that this is a major clinical trap. Posterior instability is an incredibly frequently missed diagnosis in acute settings.
It's the classic pitfall for junior doctors.
Because anterior dislocations heavily dominate the statistics, making up over 95% of all shoulder dislocations. So the classic anterior presentation is just drilled into every medical student. But posterior dislocations can be truly devastating, precisely because they remain invisible to the untrained eye. How do they actually happen biomechanically, and why do they evade detection so easily in a busy emergency department?
Posterior dislocations typically occur through distinctly different, often quite unusual mechanisms. The classic textbook presentations involve violent, uncoordinated muscle contractions.
Like the seizure.
Exactly, such as those experienced during a grand mal seizure or a severe electrocution. Alternatively, they occur via massive axial loading applied to an arm that is adducted and internally rotated, which is exactly the position of an offensive lineman aggressively blocking in American football.
So the force drives the ball straight out the back.
Exactly. And they are so frequently missed in the emergency department because the shoulder simply does not possess the obvious, squared-off, grossly deformed appearance characteristic of a classic anterior dislocation.
The patient just looks like they're holding their arm close to their chest.
Right. The arm is often just rigidly held, internally rotated against the stomach. Furthermore, on a standard anteroposterior, or AP, radiograph, a posterior dislocation can look deceptively normal.
The imaging actively tricks you.
It does. The humeral head is driven straight out the back, but on a 2D AP film, it is superimposed directly over the glenoid, making it appear vaguely seated in the joint.
What's the clue then?
The only subtle clue on the AP might be the light bulb sign, where the humerus is locked in internal rotation, totally obscuring the greater tuberosity and making the head look symmetrically round like a light bulb.
But you shouldn't rely on just the AP anyway.
Never. The absolute failure to order and correctly interpret an orthogonal view, specifically an axillary lateral or a Y-scapula radiograph, is the primary reason these injuries are completely missed.
With terrible consequences.
Devastating. This leads to patients presenting weeks later with chronic, locked posterior dislocations, having ground a massive reverse Hill-Sachs lesion into the front of their humeral head, ultimately requiring incredibly complex reconstructive arthroplasty.
It is genuinely terrifying to consider a patient walking around for 6 weeks in utter agony with a locked posterior dislocation simply because a junior doctor didn't request a standard lateral X-ray.
It happens more often than we'd like to admit.
Let us shift to one final, incredibly tricky presentation. The overhead athlete suffering from attritional instability. We have drawn a very sharp, clear contrast throughout this discussion between the violent traumatic dislocator and the MDI patient.
They are opposite ends of the spectrum.
But the overhead athlete sits in a highly unique biomechanical space. Why does assuming that all instability is either traumatic or hypermobile lead to such devastating surgical failures in elite athletes like swimmers, tennis players, or volleyball spikers?
It leads to catastrophic failure because the underlying pathology is entirely different, even if the primary symptom feels somewhat similar to the patient.
They usually complain of pain rather than dislocation, right?
Yes, usually anterior shoulder pain and a vague sensation of dead arm or subtle subluxation during a heavy throw. But a high-level pitcher throwing a fastball at 90 miles per hour is not suffering from a massive traumatic avulsion event.
It's a wear and tear issue.
Exactly. They're suffering from microscopic attritional wear generated over hundreds of thousands of repetitive extreme kinetic cycles. During the late cocking phase of throwing, the arm is maximally abducted and externally rotated.
Pushing the limits of the capsule.
Right. This places immense repetitive shear forces on the superior labrum and the anterior capsule. Over years of intense competition, the anterior capsule gradually stretches out, a phenomenon we precisely term acquired microinstability.
It just fatigues over time.
And simultaneously, the violent twisting force of the biceps tendon can cause the superior labrum to subtly fray or peel back away from the bone, creating what is known as a SLAP tear.
And if a surgeon misinterprets that attritional stretching as a traumatic injury, what actually happens in theater?
If a surgeon incorrectly diagnoses this acquired attritional capsular stretching as a traumatic Bankart lesion and proceeds to perform a standard tight anterior capsule application, the results are objectively disastrous.
Because they're treating the wrong disease.
Exactly. They will drastically over-tighten the anterior soft tissues. This non-anatomical tightening completely destroys the elite athlete's highly tuned throwing mechanics. It drastically restricts their external rotation.
Which kills their velocity.
It kills their velocity, but it also causes immense pain. Because the front of the joint is now artificially tight, it acts as a physical tether, actively forcing the humeral head to abnormally translate postero-superiorly during the throwing motion.
Oh, so it shoves the ball backward into the socket.
Right. This secondary translation creates severe internal impingement, where the undersurface of the rotator cuff is viciously crushed against the posterior-superior labrum, generating truly agonizing pain.
It's an iatrogenic disaster.
It is a catastrophic diagnostic and surgical error that routinely ends professional careers. The overhead athlete requires highly nuanced, incredibly subtle soft tissue balancing and an immense focus on kinetic chain rehabilitation.
Analyzing their core stability, hip rotation, and scapular mechanics.
Exactly. Not a generic, tight, traumatic Bankart repair.
We've covered an immense amount of ground today. We have journeyed from the violent kinetics of a rugby tackle to the hypermobile joints of a swimmer, from microscopic labral avulsions to massive structural bone deficits requiring coracoid transfers.
It's a highly complex joint.
We rely so heavily on our history-taking and advanced imaging, but astute clinical examination in the moment is still paramount. If you are speaking to an emergency medicine physician or an orthopedic trainee managing a busy trauma intake on a Friday night, what is a foolproof clinical test or a glaring red flag they can use to ensure they aren't missing a subtle posterior instability or misdiagnosing these tricky presentations?
The primary, absolutely glaring red flag is any disparity between the mechanism of injury and the radiographic findings.
So if the story doesn't match the picture.
Exactly. If a patient presents with extreme shoulder pain and an absolute inability to externally rotate their arm after a seizure or an electrical shock, you must intrinsically suspect a posterior dislocation, regardless of how normal the standard AP radiograph appears.
You have to push for the lateral.
You must demand an axillary lateral view to definitively confirm the joint is located. Now, for detecting subtle posterior instability in the outpatient clinic, the jerk test and the Kim test are truly invaluable clinical tools.
How do you perform those?
You actually load the arm at 90 degrees of abduction and horizontally adduct it firmly across the body. If you feel a distinct clunk as the humeral head subluxates posteriorly over the rim and the patient reports their characteristic pain, you have positively identified postero-inferior instability.
It's highly sensitive.
It is. The overriding key is to look beyond the obvious anterior pathology. Ask yourself critically, does the kinetic energy of the reported injury genuinely match the anatomical damage I am seeing? Is this an acute, violent tear, or is this the result of chronic attritional fatigue?
That is precisely the analytical framework we need. As we bring this deep dive to a close, let us synthesize the immense volume of biomechanical and clinical information we have unpacked into 5 definitive, memorable clinical pearls that you can integrate directly into your practice tomorrow morning.
Excellent idea.
First, age at the time of the first dislocation is the single strongest predictor of recurrence. Remember, the Havelius data, the 18-year-old and the 45-year-old, require completely divergent, age-specific clinical pathways.
Crucial point.
Second, when assessing glenoid bone loss, abandon your reliance on MRI. CT scans with 3D reconstructions and face views are the absolute undeniable gold standard to accurately quantify the bony defect.
And don't let anyone tell you otherwise.
Third, Be hyper-aware of the 13.5% to 20% subcritical bone loss threshold. This is the treacherous gray zone where you must meticulously tailor your surgical plan weighing arthroscopy against a Latarjet to the patient's exact physiological and kinetic demands.
Treat the patient, not just the scan.
Fourth, respect the dynamic glenoid track. An off-track Hill-Sachs lesion is a mechanical time bomb that guarantees failure. It mandates either a remplissage to fill the defect or a target to widen the track, preventing catastrophic engagement.
Absolutely vital for stability.
And finally, fifth, beware the attritional anterior labral injury in overhead athletes. Not all instability is traumatic. Treating acquired microinstability as if it were a massive trauma by indiscriminately tightening the capsule will irrevocably destroy an athlete's career. If you found this custom deep dive useful for refining your clinical practice, please take a moment to rate and share Deep Dive Ortho with your colleagues.
I will leave you with a final provocative thought regarding the future of our field. We have witnessed orthopedics evolve dramatically from the original open Bankart repairs through the boom of arthroscopic techniques and now towards advanced anatomical bone block procedures like the Latarjet, heavily driven by our refined understanding of bone loss and the glenoid track.
It's been a massive pendulum swing.
It has. Now, as our preoperative imaging becomes even more granular with advanced 3D CT modeling and artificial intelligence, and as our arthroscopic instruments become increasingly sophisticated, are we approaching an era where the classic open soft tissue Bankart repair becomes entirely obsolete?
That's a huge question.
Or, conversely, will the pendulum swing back in 20 years as long-term joint registry data potentially reveals the unforeseen biomechanical consequences like accelerated osteoarthritis of permanently altering the shoulder's natural anatomy with massive non-anatomical coracoid bone blocks?
It is a phenomenal question, and one that highlights just how dynamic and continually evolving the field of orthopedics truly is. The next time you see that young athlete sitting in the emergency department, remember, you are not just looking at a temporarily dislocated joint.
You're looking at a compromised foundation.
Exactly. You're looking at a shoulder where the structural integrity of the saucer has been fundamentally compromised, and the grapefruit is perpetually at risk of falling. How you manage that critical initial event dictates the entire trajectory of their athletic and physiological life. Thank you for joining us on this deep dive. Keep questioning the dogma, keep refining your clinical acumen, and we will catch you on the next deep dive.